2 minutes on the clock and your time starts now. Sarah is a 42-year-old woman of South Asian ethnicity presenting to the general practice, complaining of fatigue, weight gain, constipation and cold intolerance. She also reports dry skin and brittle nails. She has noticed gradual enlargement of her neck over the past few months. She has no significant past medical history and takes no regular medications. On examination, Sarah appears lethargic and has a palpable thyroid gland with a firm consistency and no nodules. Her temperature is 36.6, blood pressure 130 on 80, heart rate is 60 and regular, respiratory rate is 14, BMI is 29.7. The remainder of her examination is unremarkable. What is the most likely underlying diagnosis for Sarah's symptoms based on the given information? Provide 2 appropriate responses. All right, how did you all go? Some good answers coming through. So let's have a look here. And Hashimoto's thyroiditis is the most likely diagnosis here. And I think they would also accept primary hypothyroidism, and hypothyroidism would probably get you just 1 mark, less marks because it's less specific. Remember, we're trying to be as specific with our answers as possible. Iodine deficiency can technically cause it, and of course subacute thyroiditis. So excellent answers there from Demir. Now we also have, of course, some answers here from Samir. So Hashimoto's thyroiditis, fantastic, and from BDE, primary hypothyroidism, secondary hypothyroidism. I think I would just be a little bit cautious with secondary hypothyroidism because I think they would also have some other condition involved there that would then be promoting that hypothyroid picture. And given there doesn't seem to be anything else at this stage, I think you would probably have more success going with some of those other answers, but definitely something we'd be keeping in mind. Now, of course, how do we differentiate between all of those things? Well, it's almost as if we had another question lined up. Let's have a look. We'll put 2 minutes on the clock, and of course your time starts now. So what additional features of history would help confirm your suspected diagnosis? Write 4 additional features of history. All right. Hopefully you've got some great answers coming through there, and I'm seeing plenty popping up onto the screen, so very well done, guys. Again, this is really pointing towards that hypothyroid type picture, and so we're going to try and tease out, well, what are all the different potential symptoms or features of hypothyroidism that haven't already been listed? Remembering this is asking for additional aspects, additional features on history. So this is one of the great mimics. It's one of Murtaugh's favourite conditions because it could be absolutely anything, which is fantastic for us because they're asking for 4 things and we have an absolute plethora to choose from. So coming through, we've got menorrhagia or irregular or heavy menses, fantastic. Family history of autoimmune or thyroid disease, fantastic. Any past exposure to radiation, chef's kiss, low iodine in diet. Now, that would be one that I don't know if they would necessarily mark because it's something that I'm not entirely sure many people would be aware of, but we'll see how that would go. Again, we've got family history of hypothyroidism, other autoimmune disease history such as type 1 diabetes. I would just be... I think that probably would get you a mark given there are associations there. Low dietary iodine, again, we've already mentioned. They're unlikely to necessarily know that. History of neck radiation, fantastic. We do have mentioned here prior different bowel motion changes, e.g. loose stools. Now, they have already mentioned the constipation, which I think you've picked up there. And so again, that would be going back to making sure we are reading the question being asked and making sure it's not one that's already been given. So it's a very common little trap that they like to play on us and keep us on our toes. Certainly though, eye symptoms such as blurred vision isn't on here, but is actually, I think, a very valid thing to be mentioning. Lower limb swelling, I don't think there was mention of that in the STEM. Generally, that kind of mixed edema picture tends to be with more severe cases, and certainly not impossible, but I think I would probably go for some of the other questions more preferentially. Yellow pigmented deposits over tendons, again, I think would be associated with more severe disease. Now I can see there you've got popping up on here. Hashimoto's usually gets hyperthyroidism symptoms first. Correct. So again, I think you've hit the nail on the head already in terms of maybe it wouldn't be a good idea to try this answer because, and it comes back to when they write the stems, they try to give you all information you need, and I suspect they're really trying to push that hypothyroid type picture, and I'd probably focus there. But you are correct in that Hashimoto's can have that initial hyperthyroidism picture, and so you could ask that, but I'd probably focus on other hypothyroid symptoms preferentially. All right. Now, there is, of course, a part 3 to this question, as there is to every KFP question, so your time with 2 minutes on the clock starts now. What initial investigations would be most appropriate for Sarah? Select up to 4 investigations. right, so again, seeing some fantastic answers coming through, and the answers provided. So D, K, M, and N, and we have coming up D, I, K, M, and N. Now, the antithyroglobulin levels are a little bit of a trap, and that is... we'll talk about that in a minute, actually, because that's one that is coming up a little bit frequently. We have an ADKM. Yep, so again, would have gotten several marks in there. And we have T3, T4, TSH, antithyroid peroxidase antibodies. Okay, now I've actually written this out to make sure I get this correctly because it is a little bit of a tricky one and is something that I think catches a lot of people out. So initial screening is the TSH. So I'm glad to see everyone had that one in there and everyone gets that mark for K, which is fantastic. Now, normally would say if it's elevated, repeat in 2 to 8 weeks with the free T4 level as well. But given we have this patient who is quite symptomatic, I think it would be fairly reasonable to send off the T4 at the same time. Again, if we do have these kinds of features, the patient is particularly unwell, we know that the most likely culprit here is going to be Hashimoto's thyroiditis. Now, the TPO, thyroid peroxidase antibody assay, is sufficiently sensitive and specific to make this now the only recommended test to confirm the diagnosis of an autoimmune thyroiditis. Antithyroglobulin antibodies are considered to be much less specific and are now only really recommended for monitoring post-thyroid malignancy cases. Now, if you were to go on, we would recommend annual thyroid function testing recommended in euthyroid patients who have positive antithyroid antibodies, given we know that progression to hypothyroidism is more common in that patient group. It can be, we know that generally 10 to 15% of patients, even without any symptoms or features, can have those anti-TPO antibodies. And so for this, we'd have our anti-TPO antibodies, and this is one of those little traps that RACGP does like to play on us from time to time, whereby we have a female of potentially reproductive age, and we do know that thyroid conditions are often exacerbated in the setting of pregnancy, and so one thing they always like to send off is a beta-HCG. Now, this is particularly important because it has such obvious implications for pregnancy, given you really have to tightly control your TSH level in pregnancy to make sure it's safe for both mum and baby. All right. How does everyone feel about that? Throw some comments in the chat, but otherwise we will get moving along.